Assalamu alaikum wa rahmatullahi wa barakatuh. This is Dr. Maryam Habib. I am Chief Radiologist from Bahrain, from Salmaniya Medical Complex. I'm happy today to present emergency pediatric imaging. And my objective today will talk mainly about the common pediatric emergency and role of X-rays in diagnosing most of the or serious emergency in pediatric imaging. And I will mainly talk about the interpretation of urgent and serious pediatric pathologies in emergency situation. My topic today will mainly highlight the acute upper and lower airway obstruction, which is very common entity in pediatric age group. And briefly, I will try to come through acute abdomen and the pitfalls of diagnosing acute abdomen in emergency pediatric imaging. This is to highlight our area of interest today. So we'll start with, as you show here, the airway and neck soft tissue. Then I'll move to chest and mediastinum, and finally I'll talk about the abdomen. So starting with the airway and neck soft tissue, mainly under the spectrum of acute upper airway obstruction, which is very common entity in pediatric age group. Airway and neck soft tissue, usually how to approach these patients radiologically. So you will need to expose the neck of the baby laterally and frontal radiograph. So we will need two images, lateral and frontal radiograph, but for the unstable pediatric patients or irritable babies, lateral images or lateral radiograph is usually sufficient. So this is the anatomical consideration before starting with the pathologies, the common pathologies. I would love to share the normal anatomical findings in the AB and lateral radiograph of neck and soft tissue. As you can see here, this is the frontal and this is the lateral radiograph of the neck. And on the frontal radiograph, what's important to review is the patency of the airway. As you can see here, the trachea is patent, and a very important point that you should, every time looking at the frontal AB radiograph of any patient, to outline the patency of the subglottic region with smooth narrowing if you compare it to the lower trachea. So this is a frontal radiograph. This is the patent trachea with no deviation, no masses, and there is a smooth narrowing at the subglottic region, which is normally seen in pediatric age group. So coming to the lateral radiograph, which give you amazing information. And as you can see here, a lot of detail can be obtained on the lateral radiograph. And you can see starting from the pharynx, which is the naso and oropharynx. Naso is opposite to the nose and oro is opposite to the mouth exactly. If you move down, you will see the beautiful epiglottis at the level of the radio-oblique bone, which is the hyoid. And moving down from the epiglottis to this region, this is the hypopharynx. And inferior to that, you will start having the subglottis, which is normally at C5, 6 level. If you count with me, this is the second, 2, 3, 4, 5, 6. So this is the 6th cervical vertebra. Opposite to that, there is slight narrowing, which is appreciated well in the AB radiograph. Moving downward, you will see the beautiful trachea. So you need to identify your normal anatomy, and additionally, you should always comment upon the prevertebral soft tissue. The prevertebral soft tissue should be homogeneously seen, thin at the C2 and slightly thicker at the lower cervical area. I'll go more in detail on the upcoming slides. So this is again a lateral radiograph. As you can see here, there is a smooth outline of the prevertebral soft tissue, and very easy to recall that it should not exceed 7 millimeter at C2 and not more than 2 centimeter at C7. So C2 7 and C7 2 centimeter. This is normal. And you should always obtain or review the alignment of the cervical spine, the vertebrae. You have 4 vertebral lines, which should be aligned together with no disruption, which is very important in trauma cases. But today, unfortunately, there will be no time to review the traumatic injuries of the pediatric age group. But whenever you are looking at the lateral radiograph, please pay attention to the orientation and normal alignment of the vertebral bodies, and especially the atlantoaxial articulation. So, furthermore, you need to know that in pediatric age group, it's very common to see a lymphoid hyperplasia, which is commonly seen at the adenoid tissue. As you can see here, this is the adenoid, which is usually in the previous images, you don't see anything rather than the patency of the nasopharynx. But here you can see a lobulated soft tissue at the level of the nasopharynx, at the level of the age or pediatric age group. This is commonly related to adenoid hypertrophy upon the nasopharynx. Lower down, which is also common to be seen on pediatric age group, is the large tonsil, which is this one. Okay, so this is the lingual tonsil, which is enlarged here. Again, you can see the prevertebral soft tissue, because we will review these anatomical landmark again and again in our presentation. So the first entity as an emergency upper airway obstruction is the group, which is usually seen between 6 months and 3 years age group, and it is very life-threatening condition. It's usually inflammatory, infectious in origin, related to the viral infection, and promote and fast diagnosis is very crucial in these patients to prevent the complication. So as you can see here, as I stated earlier, this is the frontal radiograph of the neck of a pediatric patient, and you can see this is slight narrowing, this is normal control image. But if you come to this group patients, the patients with the group, you can see that the smooth tapering is lost here. Instead, you see a significant narrowing at the subglottic region, which is giving the typical sign of steeple sign, which is steeple sign, as you can see here. And this is typical sign of a group, as you can see in AB radiograph. On the lateral radiograph, again, you can see the changes of subglottic inflammation, which is usually, as I stated earlier, related to infection with viruses. And you can see, as I mentioned, at C5-6 there should be slight narrowing, but not that much. So this is an abnormal narrowing. In addition, you can see the hyper distension of the pharynx superiorly and proximal to that narrowing. This is indicate inflammation of the subglottic region in a group patient. Again, another patient having the narrowing at the subglottic region, and in addition to that, you should pay attention that the airway here is indistinct, and you don't see the nicely outlined pharynx of the subglottic region, indicate underlying inflammation and cellulitis. A very important point here, the diagnostic birth here, that although it is possible in medical situation to have any common categories, but although it is possible that viral crop is seen in any age group, but you should pay attention that if you have a crop in the out of the normal range of the group, out of the range group aging, you should suspect alternative diagnosis, such as ingestion of foreign bodies or bacterial crop, which names are membranous. So any atypical presentation or any symptom that does not resolve within a few days, you should suspect an alternative categories or alternative diagnosis, including the ingestion of foreign bodies and subsequent subglottic inflammation. The second entity is acute epiglottitis. Also, it is very life-threatening condition. Barrier to the vaccination of parainfluenza, it was the mean age group was between 3.5 years, but after the introduction of the vaccination, it came around 14 years and it dramatically decreased the incidence in age or younger age group of pediatric population, and coming relatively at elder age group of 14 years. So, acute epiglottitis is an inflammation, viral infection and inflammation of the epiglottis. This is a lateral, two different patients, lateral radiograph of the neck showing a significant and severe inflammation of the epiglottis. Okay, so this is the epiglottis here in this scenario, while it is here in this other patient. If you remember the normal, epiglottis should be very finger-like projection, small and thin, and here you can see it like a thumb sign appearance. A thumb sign appearance, which is seen typically in acute epiglottitis. And additionally here, furthermore, you can see this thickening of the soft tissue, which is the epiglottic fold, which is also inflamed and swollen. So this is the acute epiglottitis. The third entity in upper respiratory obstruction is retropharyngeal infection. In the retropharyngeal infection, you should have a close watch upon the prevertebral soft tissue thickening. As I described earlier, it should not exceed 7 millimeter at C2 level and not more than 2 centimeter at C7. But here there is obvious thickening of the prevertebral soft tissue. Just pay attention whenever there is thickening. Take proper clinical history of the patient. Most of the retropharyngeal abscesses and inflammation preceded by upper respiratory infection and rupture of one of the inflamed lymph nodes that give you cellulitis and subsequent abscesses. Early diagnosis and early detection of this thickening may prevent a further complication of abscesses and large cellulitis and phlegmons. So here you can see a very thickened prevertebral soft tissue causing narrowing of the airway column with displacement anteriorly. The fourth entity is upper airway obstruction related to ingestion of foreign bodies. If you are likely, this is likely related to unwitnessed scenario by adults. So if you are a lucky person, you may have a witnesses telling you that there is a history of ingestion of foreign bodies, but you should put this possibility whenever there is no typical witnesses or not typical clinical information for the pediatric age group, because it is very serious condition. This is lateral again. You can see a lateral radiograph of the neck of a pediatric patient. As we stated earlier, this is the epiglottis, okay, at the level of the hyoid bone. In pediatric age group, you rarely see the cartilaginous of the thyroid or cricoid cartilage. So the only things you may see as a radio-OP is the hyoid bone. Other than that, should raise a suspicion for you as general practitioner or pediatrician that this may be related to radio-opaque foreign body. But unfortunately also, to be mentioned here that these days, a lot of foreign bodies are radiolucent and bronchoscopy or CT may be needed for further assessment of these patients. But here, this is a typical appearance of the cylindrical shape of fishbone ingested directly at the upper margin of the epiglottis. The epiglottis is slightly swollen here, maybe started to have an inflammatory reaction related to this foreign body. Otherwise, you can see that the prevertebral soft tissue is good, no perforation, no air elsewhere other than the airway column. You can see the vallecula, which is just anterior to the epiglottis, which is a common site of foreign body, and the piriform sinus with the normal air outline. So there is only radio-opaque foreign body here, no worrisome features of complication. Another large foreign body, this is unfortunately a Down syndrome patient with ingestion of chicken bone, chicken bone, which is a large here, as you can identify. So again, the only radio-opaque shadow is the hyoid bone. This is an abnormal object which is seen in the prevertebral soft tissue. Additionally, surgical emphysema and lucency all around the prevertebral soft tissue at the level of the trachea and in the anterior neck space. This one is a typical complicated ingestion of foreign body complicated by a perforation either by trachea or esophagus. So subsequent modality of studies is needed to emphasize upon the area of perforation. This is again another foreign body in the prevertebral soft tissue. You can see that there is a slight thickening of the prevertebral soft tissue as a reactive inflammatory process due to the ingestion of this foreign body object. So we talk about the airway and neck soft tissue briefly. Hope it was benefit for you. We will move to chest and mediastinum. Just to start with, you need to have a good review areas whenever you are reviewing a chest X-ray. You should second to review the secrets area on the chest radiograph. The secret area are the abscesses on both sides, which should be typically symmetrical. The soft tissue around the chest area, the retrocardiac region, which should be symmetrical on both sides, and any density or air behind the cardiac shadow should be reported as abnormal. The patency of the airway and the symmetry of both lung fields. So, I will be talking about acute lower airway obstruction as we finished the upper airway obstruction. So now, lower airway obstruction mainly under two categories: infectious inflammatory or also aspirated foreign body which lodged inferiorly. So we'll move to first category, which is the reactive airway disease. The most common reactive airway disease that we know is the asthma. Asthmatic patient usually does not need any imaging or radiograph for their asthmatic problem. But when you have an critical ill patient or exacerbation, significant exacerbation of the pain, a radiograph should be obtained to exclude any complication of the asthma. So this radiograph for asthmatic patient, what I want to highlight here, that as a general practitioner or a pediatrician or even radiologist, you should easily identify the hyperinflation of the lungs. In pediatric age group, more than 6 ribs anteriorly considered hyperinflated lungs. So let me count here. So this is the first, which should not be missed. Okay, most of the practitioner, they forget to count the first rib. So this is first, second, third, fourth, fifth, sixth, and seventh. So more than 6 consider hyperinflated lung. So there is a slight increased lucency of both lungs. They are hyperinflated, evident by more than 6 ribs anteriorly. And in addition, you can see that there is a slight flattening of the hemodiaphragm. And on lateral radiograph, again, you will appreciate the flattening of the hemidiaphragm along with increased lucency in the retrosternal space. So all of these findings give you an impression of hyperinflation. In history of asthmatic patient, this is usually related to asthma. And sometimes you can see an inflamed bronchi which show a thickened wall. So this is only asthma. We don't have any evidence of complication here in this scenario. Another entity of an infectious airway disease is bronchiolitis, which is infectious in origin, usually seen in under 2 years of age in pediatric age group. You have similar findings if you compare it to asthmatic patient, but it is non-allergic or non-inflammatory in condition. It is infectious etiology. So again, you will note that it is hyperinflated lungs. If you count, these are more than 6, 1, 2, 3, 4, 5, 6, and 7. 7 rib anteriorly, slightly downward slope or flattening of the diaphragm. Additionally, what you should pay attention if you suspect the bronchiolitis, look at the paracardiac and parahilar region for any congestion and inflammation of the small airway. So here you can easily tell that there is a lot of dirty appearance around the cardiac area and parahilar region with you can name it like a prominent bronchovascular marking, and additionally you have thickened bronchi, which is very prominent here. This is typical findings in bronchiolitis. This is not very the aim of reviewing these, not only to diagnose, also you need to exclude the major complication of these entities which cause hyperinflation of the lungs. With hyperinflation, you may expect rupture of the alveoli, associated pneumomediastinum and pneumothorax, which are life-threatening conditions. So, moving here, this was an asthmatic patient with acute exacerbation and shortness of breath. And if you can see here, you can outline the abnormality within the secret areas which we reviewed. So the neck, lower neck, cervical soft tissue show lucency and air here, suggesting surgical emphysema. Additionally, if you see a surgical emphysema, look carefully at the level of the lungs if there is any associated pneumomediastinum or pneumothorax. So this is extensive surgical emphysema of the subcutaneous tissue. If you go and look closely to the mediastinum, you can see the line of the pleura and lucency here just along the cardiac shadow, and this is suspicious for minimal pneumopericardium or pneumomediastinum. No, both lungs are normal in density. There is no pneumothorax, and they are hyperinflated symmetrically. Again, this is a sequelae of bronchiolitis. As you can see here, more evident of these are two different patients. This is complicated asthmatic patient. As you can see here, clearly you can identify the pneumomediastinum with air lucency seen at the left paracardiac area, in addition to extensive surgical emphysema. Also, you may notice the continuous diaphragm sign here. If you can see, there is air. This line may be seen in pneumomediastinum, sometimes can be seen in pneumoperitoneum. But in this setting, it is related to pneumomediastinum. In this case, you can see very ugly, dirty appearance of the lungs. This is a case of bronchiolitis. The bronchovascular marking is very obvious and prominent along the paracardiac and parahilar region. In addition, it's complicated with patchy consolidation in the upper zones, thickening of the bronchi with minimal pneumomediastinum. Atelectatic bands is also noted here. These all are sequelae of bronchiolitis and hyperinflated lung with subsequent ruptures and pneumomediastinum and subsequent infection, and superimposed bacterial infection should be suspected in similar scenarios. Just to show you the different type of pneumothorax, this is very subtle with no tension. So this is non-tension pneumothorax. As you can see, a small pleural line with peripheral lucency showing no lung marking, which is typical for pneumothorax. This is another patient with massive right-sided pneumothorax. In addition to that, you can identify the collapsed lung, right lung, and significant shift of the mediastinum to the left side, which is typical tension pneumothorax, which is life-threatening condition, needs urgent intervention. This is another patient with mild tension pneumothorax. As you can see, this line of pneumothorax, which is small but started to have a tension effect upon the adjacent lung tissue. The lung started to be medially displaced, though that the mediastinum is still central. Talking about the lower airway obstruction, we finished the infectious and reactive allergic condition. We'll move to lower airway foreign bodies. Lower airway foreign bodies is very important entity which should be suspected in sudden deterioration or abnormal prolonged cough or abnormal upper respiratory or lower respiratory symptoms with no clear histories, especially as I stated earlier, if there is no witnesses of ingestion. So if you have a patient presented with lower respiratory symptoms, you may ask for a radiograph. If your initial radiograph show asymmetry of both lungs, you should pay attention on that. Any asymmetry is abnormal, either related to malrotation or real asymmetry. In this X-ray, you can see there is no such malrotation. The symmetrical appearance is good and the exposure is good, but still you can see that there is asymmetry of both lung fields being more hyperinflated on the right side as compared to the left. In addition, there is more lucency on the right as compared to the left. This should give you a suspicion of air trapping on this area. So to further confirm your suspicion, you should ask for expiratory film. This is a normal for a full inspiration film, which is usually requested by the radiological team. They will ask you to inspire it and take a full inspiration X-ray, but you may ask for expiratory film to confirm your suspicion of air trapping related to ingestion or blockage of the airway. So what you will see on the expiratory film that there will be a persistent hyperinflation of the suspected area. So if you compare this to this, the left lung volume collapsed, which is normally less than the expiratory film, whereas the right lung persistently hyperinflated and lucent, so air trapping is there. This patient was found to have a small apple piece ingested in the right main bronchi. So we finished the neck, the chest and mediastinum briefly, and we'll move to abdomen radiograph. In acute abdomen, approaching abdominal radiograph is very important. We'll talk about the identification of the external tube, external and internal lines and tubes in pediatric age groups and sick babies. Other objects like an external artifacts or ingested foreign bodies, air air and abdominal radiograph is very important highlighted title, which need to be aware about. The air in the abdomen is very tricky. Identifying the abnormal air within the abdomen may lead you to proper diagnosis and saving life. So air, whether it is intraluminal, within the bowel, extraluminal or free air, and you should identify the normal appearance of the solid organs and soft tissue. This is the normal radiograph for a pediatric age group patient, showing you the normal distribution of the gas in the center of the abdomen and the periphery, central related to the small bowel, and the periphery usually the pattern of the large bowel loops. You should identify the normal soft tissue density of this liver and the spleen, gas within the gastric lumen, and in every single patient, don't forget to look for the presence of the air within the rectum. So this is the normal appearance of the gas distribution in a healthy abdomen of pediatric age group. So identification of the tubes and lines. This is a common lines in sick babies or very younger age group of pediatric population. You should always comment about the proper position of these tubes and lines, but I will briefly just identify these lines just to have an idea. This is the endotracheal tube. This is the, which is seen only on the trachea. A long line, which is seen from the airway down, within the esophagus down to the left side of the abdomen, going to the gastric lumen, which is NGT or nasogastric tube, two umbilical catheters, the venous, which is going straight upward, and the arterial catheter, which is having a downward slope, then upward migration. Just to highlight again, because ingestion of foreign bodies is very critical and very crucial in pediatric age group. Identify any abnormal objects whenever you are exposing the abdomen, chest or neck spaces. Identifying the number of the radio-oblique foreign bodies, and pay attention to the dangerous part of the foreign bodies, including the batteries, magnets, and sharp objects, which needs an urgent intervention. Air, again, I will emphasize on the air in the abdomen, looking for pneumoperitoneum, bowel obstruction, and constipation. Bowel obstruction, we have in pediatric age group 4 general criteria. The obvious things for every single medical doctors or practitioner is looking for bowel dilatation or air fluid levels. Actually, these 2 points are very obvious, and these 2 points are direct sign of bowel obstructions, which does not need a lot of efforts from your side. The important thing that you detect the bowel obstruction with the fine details or abnormality before going to massive dilatation and air fluid prominence. So always pay attention on abdominal radiograph for the distribution of the gas rather than the dilatation. If it's dilated, it will be obvious, but the abnormal distribution or orderliness, that's mean how healthy that the bowel is there in the abdomen, give you a hint what's the diagnosis and what is exactly going on in the acute abdomen, including the possibility of acute bowel obstruction. And always consider the imaging with the clinical scenario of the presented patients. So just to state here that there is obvious obstruction, bowel obstruction here, evident by multiple dilated and distended bowel loops all over the abdomen, and multiple air fluid levels. And as you can see here, probably there is no air within the rectum, indicating a small bowel obstruction. You should pay attention of any complication, including the gas over the portal venous system or a pneumoperitoneum. But what I want to convey, the message here to be conveyed, that you should pay attention about the subtle findings of bowel obstruction, as we will review in the upcoming slide. So this is obviously, everyone can tell that this is a distended abdomen. So looking at this patient, this is a premature infant, a newly born premature infant. And you can see here also, there is obvious distension of the bowels. But in addition to the distension, which is sometimes could be seen in normal, as a normal finding, you can see how dirty is the appearance of the bowels in the right lower quadrant area. So this is a frontal radiograph showing distended of multiple bowel loops. Additionally, you have to outline these bubbly appearance related to the bowel. And in a premature, newly born babies, this appearance is very typical findings in necrotizing enterocolitis, which is neck. And this is suspicious for intramural gas. Intramural gas, that's mean within the wall rather than intraluminal. This is the same babies or same patient. Suspicion of perforation was suspected clinically. So they asked for lateral decubitus film. Lateral decubitus film for minimal pneumoperitoneum is very good actually modality to be chosen. And it shows a minimal free air to be on dependent superior aspect of the abdomen. So all of these air is outside the lumen. And again, you can see the bubbly, ugly appearance of the bowel with target sign and air around the wall. This is the complicated neck with the venous gas at the area of the liver soft tissue density. You should not be able to see any lucency or gas material. So if you have a clinical setting of neck, baby with neck and branching gas at the level of the liver, you should suspect a portal venous gas. Now, coming to the important point in the abdominal radiograph, this is a patient with irritability, colicky pain, and he is 7 months old. If you see at this image, you will not see the ordinary sign of bowel obstruction, which I already commented previously, the distension and air fluid levels. As you can see here, this is supine and this is erect, evident by the air fluid level here. So there is, instead of distension, there is a paucity and very minimal gas seen within the abdomen of this pediatric patient. Distension is worrisome feature, and paucity of the gas in the pediatric abdomen is also another worrisome feature for underlying bowel obstruction. Whenever you see abnormally distributed gas within the abdomen and paucity or over distension, both are alarming features. As we can see here, there is a decreased bowel loops at the midline of the abdomen. Additionally, there is unhealthy looking 2 bowel loops seen in the right upper quadrant, which are featureless. Featureless, that means they are not showing typical histration or folds of the small bowel loops. And they are like a sausage type appearance with featureless looking. This is very unhealthy loops, should be described carefully and look for any other associated signs of bowel obstruction. Furthermore, you can see in the erect radiograph, there is the similar loops show air fluid levels. And additionally, if you can see to this bowel loop, you can see an abnormal cut-off of the inferior margin with crescent-shaped appearance. So you have a paucity of the gas in the midline of the abdomen, abnormal featureless lobes here with a crescent-shaped bowel loop in this lower left abdomen. These are an alarming features of underlying bowel obstruction and commonly seen in intussusception. So again, this is to highlight the abnormality. Again, another patient with intussusception showing paucity of the air in the midline of the abdomen, abnormal crescent shape of this slightly prominent loop, and this is a slightly prominent caliber of the bowel on this area, which is the lower right abdomen. If you can concentrate more here, you can see a rounded density with rounded lucency, giving the target sign appearance. If you join or combine all features together in this 2-year-old female with irritability, colicky pain, intussusception should be raised up. Constipation is very important entity in pediatric age group and should not be underestimated, because constipation sometimes, if ignored, can lead to serious complication, including the overflow incontinence, toxic megacolon, and perforation, in addition to psychological effect upon the babies and children. Would they be afraid to go to the toilets in public areas? So this is a typical frontal radiograph of the abdomen showing that the rectum is significantly distended with fecal material. Also, again, you can see the fecal material distended through the whole colon in the right and left-sided colon. So this is a constipation. Coming to my mind, bad experience with my daughter. She was 9 years old, started to have slight diarrhea, nausea, and vomiting, diagnosed as a viral gastroenteritis. Symptoms on and off during 2 weeks. She was unable to take large meals, nauseated on and off. I was struggling through the emergency again and again. Viral gastroenteritis was suspected, giving supportive IV, Brimbaran, Buscobans, but not resolving over maybe more than 2 weeks. Eventually, I booked with a pediatrician who just palpated her abdomen. She said, I'm not happy about the how hard is her abdomen. I think there is a lot of fecal material. Let we see how the radiograph is going on. We imaged her and it showed a fecally loaded colon. Enema was given and dramatic improvement. We saw a dramatic improvement, and it was diagnosed as a constipation. The point here that sometimes even they gave a history of diarrhea. This can be a sign of constipation because in some situation, as a reactioner to the prolonged or chronic constipation, the baby our child may start to have a small watery diarrhea because of the constipation. So clinical evaluation, clinical examination and palpation of the abdomen is very important to decide what is the exact diagnosis. And this is the typical radiograph for pneumoperitoneum in very young baby, showing you the whole signs of pneumoperitoneum, which is the football sign, the all pneumoperitoneum in the freely air within the intraperitoneum, giving you the football sign, the falciform ligaments, the double wall sign of the bowel outlined by the air, and the inverted V shape. So this is typical appearance of a pneumoperitoneum, and also you can see the continuous diaphragm sign. This is easy to be detected in any clinical scenarios, but not all signs may be present in all times. So try to pick up the early signs of pneumoperitoneum. And this is, I think, our last example case, which show also an abnormally dilated large bowel in the midline, or large containing air structure in the right and midline of the abdomen, which is resembling the gastric shape. So in addition to that, you don't see any air elsewhere, and the rectum is empty, no air in the rectum. This is probably representing an distended stomach with gastric outlet obstruction. And pediatric age group, early months of age, with this scenario, projectile vomiting, we should suspect biliary stenosis. The second step is ultrasound, which will give you a very good impression upon the biliary stenosis. So we finished our topic for today. Take home message: never underestimate the power of the X-ray, even with this sophisticated world with the high advanced modality of imaging. Still, the X-ray is of a magic and powerful benefit, and would give a lot of information in pediatric emergency. So not always the most expensive modality of radiology will give you the most appropriate diagnosis. Second, not every patient needs a scan of advanced imaging. Always, when you are dealing with pediatric age group, consider the risk of radiation, high cost and availability of the requested modality, and never underestimate the plain X-ray as a powerful informative method of imaging. I think I finished my topic. Hope it was very useful for you. Thank you for your attention and listening. Wish you a happy Friday, and any question you may contact me through my page, Radiology Doctors. Thank you for your attention. مع السلامة.